Okay, so I think we're live now. So hi everyone, welcome to the ophthalmology teaching session by MedTech. We'll just give it a few minutes to see if a few other people will join before starting. So we give it until about 5 past to start. Okay, so shall we start with the slides? Yeah, we'll just introduce myself. So I'm Alex. I'm a FY1 doctor in Manchester.
My name's Shantae. I'm an FY1 doctor, also in Manchester as well.
So we're going to talk about ophthalmology today, and we've broken it down into 6 main categories. We're obviously going to do the structure that I'm sure you guys are familiar with now, where we do 10 multiple choice questions. We sort of give you guys the questions, give you time to answer, and then we show the answer and then go over the topic, talk about the topic. I think just when you're trying to be methodical with your ophthalmology questions, start to look at the presentation and begin by breaking it down into if it's an acute or chronic condition, so like gradual or sudden presentation, if it's a red eye or not a red eye, and if it's painful or not painful. And then, of course, sight's important, but with almost all conditions, sight will be impaired. So that's not necessarily like the type of vision loss. So say if it's like the periphery or sort of like color vision loss, that can be helpful. And as well as if it's bilateral or unilateral. So try and be like methodical going through the presentations to get your differential diagnosis list. So we'll start with the first question here. So we'll put a poll out, yeah. Okay, so we'll show the answer. So watchful waiting. So hopefully you managed to work out the diagnosis, which is a conjunctivitis. So just looking at the presentation, so it's an acute presentation of red eye. Isn't particularly painful, which I guess is important here for sort of coming down your differential lists. Other key parts of the history, so the fact that he's had like choroidal symptoms leading up to this, and then on the examination, sort of the serous discharge and the bloodshot conjunctiva, sorry, as well as the swollen lymph nodes, will help you sort of with the management. So it's sort of leaning towards a viral cause for his conjunctivitis rather than bacterial. And we go through sort of the different types of conjunctivitis and treatment. So with bacterial conjunctivitis, you more get like a thick plurulent discharge, which is different from the serous discharge, so more like just watery discharge that the kid had, which is more indicative of viral. So if it is bacterial, and this is usually a diagnosis made just clinically from how they present, you treat them with topical chlorophenol, usually, which is an antibiotic. However, with viral conjunctivitis, it's very common. Usually there's like a preceding viral urti, which sort of this was present in this case, as well as sort of like palpable tender lymph nodes like periauricular, cervical. So you would treat this viral supportively, which was so essentially the question was getting you to determine if it was bacterial or viral. You also can get allergic, which is just like hay fever or dust. And just with the presentation, it didn't seem like it was like an allergic cause. He didn't have any history. It was sort of like quite sudden. So it wouldn't be suitable to treat with like topical antihistamines or topical mast cell stabilizers. Conjunctivitis is usually something you don't need to refer to ophthalmology. The only sort of if it's resistant to treatment, then you definitely would. And the other reason you might is, or you definitely do, is in neonatal conjunctivitis, so conjunctivitis in the first 30 days of life, because it's likely caused by gonorrhea, which would need, so that's an urgent ophthalmology referral. Okay, so just speak about some other not a question quite yet, but just some common other conditions. So blepharitis, which is inflammation of the lid margins. So it's sort of like dry, crusty, sort of like eyelid margins, associated with acne rosacea and also seborrheic dermatitis. And it's almost like those seborrheic dermatitis symptoms, but just on the eyelid margins. Can also have staph infections with that as well. A stye is a infected meibomian gland, and they're painful, as opposed to chalazion, which is just a blocked meibomian gland, and they're non-painful. So these three conditions, you tend to treat them conservatively. So that's like so like eye hygiene, so washing the eyes out, warm compresses over the eyes to sort of help with those meibomian gland, so that they sort of like are less clogged up. There's some other key lid conditions. So entropium is inwards rolling of the eyelids, and this can actually be this can cause the eyelids, the eyelashes to come into contact with the cornea and the conjunctiva. So this would need a referral to ocular plastics, because that continual sort of friction between the eyelids and the cornea can actually be damaging to the cornea. Ectropium is the outward rolling of the eyelashes, and trichosis is sort of these eyelashes that, rather than growing outwards, they grow inwards. So they again are touching the cornea and the conjunctiva, so that can lead to issues. So you have to remove the eyelashes in those situations. Dry eye disease, very common condition. Lots of different causes, but the main ones are meibomian gland dysfunction. So the meibomian glands in the eyelid margins or in the eyelids sort of help form part of the tear film. So if they're blocked, then sort of the components to tears aren't right, which can lead to like increased evaporation. Hence why you'd get dry eyes. And also blepharitis can also be a cause of dry eye. And for medical school exams, it was important to consider autoimmune causes such as Sjogren's disease. Management is, again, conservative. Treat what you can treat. So control any allergens, treat the blepharitis, the meibomian gland dysfunction. So again, lid hygiene is important. Stopping the smoking, because I assume that the smoke would sort of disrupt the tear film, or just be an allergen as well. And then artificial tears, of course. So now we're going to question 2. Okay, so we go on to the answer. So herpes simplex virus. So this is a presentation of keratitis. So we have the acute red eye, that's painful, and the reduced vision as well. So all 5 of those options are causes of keratitis, infective keratitis. However, the dendritic ulcer, which we see there in the cornea, is indicative of herpes simplex virus. So keratitis, so it's inflammation of the cornea, usually infection, but can also be other sort of autoimmune conditions. And it is life-threatening, so you would always refer this patient. That's why it's really important to sort of distinguish between keratitis and conjunctivitis. So really careful examination of the eye to see if there's any involvement of the actual cornea, and also the fact that pain, sort of the keratitis is a lot more painful. There is a little bit of a caveat to that, which I'll touch on here. So contact lenses are a big risk factor, of course, because they're sort of, you can have microbiomes forming on them, and then you're always putting them on direct contact to the cornea, as well as being neurotrophic, which means that the cornea has lost sensation. That can be due to a few things, such as diabetes or previous herpes infections. Why that's an important risk factor is because the patient might cut their eye, or they're more likely to begin with to cut their eye, just because they don't have sensation, so they might not notice certain things in their eye, and then the healing process is also impaired, so that leads to more chance of keratitis developing. Fluorescein is added to the eye to assess the corneal surface, and fluorescein sort of stains this yellow color. where the epithelium, so the surface layer of the cornea, cell layer of the cornea, is disrupted. And that's where we can get these dendritic ulcers forming with HSV. So we can go on some causes. So viral, so we just mentioned HSV. With the dendritic ulcer, you treat that with topical acyclovir. Herpes zoster virus is it's shingles, so you get this. So the virus within the trigeminal nerve goes down the ophthalmic branch. You have a development of this vestibular rash on the side of the face, and it's called Hutchinson's sign, where you also notice the rash on the nose. And if the patient presents within 72 hours, you treat with oral acyclovir. Just go on to the next slide. So bacterial keratitis is most commonly caused by Staph aureus. However, Pseudomonas is an important one, especially for contact lens wearers, and you treat this with topical chlorophenol. Acanthoma, so that's like found in fresh water, so people that are swimming in sort of like rivers or like open water, that's a risk factor for them. You can get fungal, and then you can also get non-infective causes, so like photokeratitis. So there's something called welder's arc, where people who weld, that the sort of sparks that come from that can cause keratitis. So, and then like exposure keratopathy, so that's sort of with if the patient isn't able to actually like close the eye properly, because potentially like a facial nerve palsy or the ectropium that we mentioned before, then that can be a risk factor for sort of like fungal or any form of like infective keratitis to form. Also autoimmune causes, and then chemicals, so like chemical burns to the cornea. Important complications are ulcers that can then predispose the patient to endophthalmitis. Treating keratitis is really important, because if you start to develop a scar from the healing process, then that can obviously impact the vision, and you might need to actually perform a corneal transplantation. So these patients are always urgently referred to ophthalmology, and they're very carefully followed up by ophthalmology. So we go on to question 3. And if anyone has any questions just throughout the presentation, just pop them in the chat, and we'll answer them. Okay, so the answer is hypermetropia. So we again have another presentation of an acute red eye, painful as well, with some reduced vision. So hopefully we got to the diagnosis of acute closed angle glaucoma. Few reasons why we would lean towards that. So the fact that it's hyperacute, so it's a very sudden onset. The fact that it came on in the evening can mean that that's when the pupil is dilating as it gets dark. And we're see that dilation of the pupil is a risk factor. And then also from the actual like slit lamp examination, so we can see that he's got these semi-dilated non-reactive pupils, which is a classical sign for acute close-angle glaucoma. And then why is hypermetropia a risk factor and not myopia? So hypermetropia is long-sightedness, which is which means you have a small eyeball, and therefore you'd have a smaller angle. So it's more likely to close essentially, as opposed to myopia. Myotic drops are what you use to treat this, so that's when the pupil becomes small. The black ethnicity has nothing to do with increased risk, and sort of a condition like conjunctivitis wouldn't increase the risk for this patient. And actually in the history here, so you can see his prescriptions plus 3.5 diopters, which is a long-sighted prescription, which tells you that he's got hypermetropia. And also he's got an increased pressure in the eye, 28. So what is acute closed-angle glaucoma? So it's so glaucoma itself is a group of conditions that lead to irreversible and progressive optic nerve damage. It is associated with increased intraocular pressure, but it's not always due to that. However, in acute closed-angle glaucoma, the angle where so the space between the posterior part of the cornea and the iris becomes close, so the iris sticks up against the cornea, which means that the aqueous humor can't flow out easily from the trabecular meshwork, which means that you have disrupted that equilibrium within the anterior chamber of the eye, so you have an increased intraocular pressure because aqueous humor can't leave the eye, and that can be damaging to the optic nerve. So we've spoken about risk factors there. It's mainly sort of pupil dilation. And then we've seen the presentation. Classically, you get this semi-dilated non-reactive pupil, raised pressure on tonometry when you sort of assess the patient clinically. So normal range is 11 to 21, so it'd be higher than 21. And clinically, so like if you in an ophthalmology clinic, you use a gonioscope, which is sort of a mirrored lens to have a look at the angle to see if it was closed or not. And the way you treat acute closed-angle glaucoma, so you want to make the pupil small and you want to reduce the pressure in the eye. So you give pilocarpine, which is a myotic eye drop, so it constricts the pupil. You can give acetazolamide, a carbonic anhydride inhibitor. IV mannitol as well reduces the intraocular pressure. However, definitively, you do a peripheral laser iridotomy, so you're creating a small hole in the iris. So you're giving sort of like an alternative route for the aqueous humor to leave the anterior chamber. So you wouldn't get this like sudden buildup of pressure within the eye. Okay. So we can go on to question 4. Okay, so show the answer for this one. So, darkening of the iris. So, essentially, this is obviously a very different presentation. So there aren't any symptoms or change in vision. However, the ophthalmologist has the optometrist has referred because there's an increase in intraocular pressure. So 26 and 25, so it's above 21, which is the upper limit of normal. Also on slit lamp, we see there's an increase cup to disc ratio, which shows that there's already damage to the optic nerve. So it will be a little bit surprising that the patient doesn't have any symptoms or reduced visual acuity at this point, but for the sake of this question, they haven't. So that's why the patient started on latanoprost. So a key side effect to cancer patients on would be darkening of the iris, and they also can get sort of lengthening of the eyelashes. Is another one, not rather than loss of eyelashes. So open angle glaucoma. So again, the definition of glaucoma is this irreversible progressive optic nerve damage, usually associated with increased ocular pressure. And within sort of like chronic, so this isn't obviously an acute picture. The cause of this open angle glaucoma is the angle's open, but the trabecular meshwork in the angle is sort of starts to get blocked up. So the flow of aqueous humor out of the anterior chamber is less, and that gradually increases the pressure of the eye. Most of the time, it's just picked up at routine checks. However, patients can start to notice sort of like peripheral visual changes, so loss of peripheral vision. Essentially, you get this thing called a central scotoma, and that develops to this tunnel vision where you only have the central vision preserved. So investigations, so tonometry, which is assessing the intraocular pressure, so it's going to be raised. Slit lamp's really important. You're going to look at the disc, and a normal disc to cup ratio is anything less than 0.7. So if the disc to cup ratio is more than 0.7, then that's a sign of the optic nerve damage. The disc will also look pale as well. You'll do visual fields, so you can sort of assess sort of the patient's vision to see where they've got loss of vision, and you can see this sort of like nasal step, central scotoma, and then you develop into tunnel vision. You can do OCT scans, so these are cross-sectional imaging of the sort of the retina and the optic nerve to get a picture of the damage that's caused, and then a gonioscope again, where you try and look at the angle, but I guess in a sort of a more chronic condition, assessing the angle. You're not suspecting this patient as a closed angle, but it's still an investigation you could do. So certain risk factors, so diabetes is a big one, as well as corticosteroids. So patients on long-term steroids are increased risk of developing glaucoma due to raised intraocular pressure. So how you treat glaucoma, so you can do selective laser trabeculoplasty. So you're just creating sort of to the actual trabecular meshwork, sort of lasered that part to help with the flow of aqueous humor. Latanoprost, so prostaglandin analog, that's usually first line. Timolol, which is a beta blocker. Dorzolamide, carbonic anhydrase inhibitor, and brimonidine, an alpha-2 androgen receptor agonist. And you can do a trabeculoplasty as well, which is a certain surgery to sort of create a blep, so like an alternative sort of to again increase the outflow of aqueous humor. And then getting back onto the point, onto the question that we had, so latanoprost can cause iris pigmentation and lash growth. Timolol beta blocker, so it's contraindication in asthmatics. Dorzolamide can sort of cause like an allergic, like asthmatic side effect profile, and then brimonidine, avoid in MOIs, and tricyclic antidepressants. You can get this hyperanemia of the sclera, so you would get sort of like redness of the sclera. Okay, so next question. Okay, so the answer, so hypercalcemia. So first, so I just apologise for this because I've just noticed that it says on the examination that the left eye is cloudy, but this patient has a cloudy right eye. Sorry if that put anyone off. But basically, this patient has a cataract, so fairly obvious, fairly sort of like routine presentation. So painless, eyes not red, but he has had this gradual sort of loss of vision, going back to sort of our stepwise approach to thinking about sort of creating a differentials list. Also, like one of the things you get with cataracts is halos around the lights. So the question is probably a little bit difficult. It's more thinking of ones which are like would obviously cause a cataracts and ruling them out. So smoking and diabetes are like big risk factors for developing cataracts. So steroids, and the myotonic dystrophy is one of those sort of conditions that you just sort of like for medical school exams have to sort of associate with developing cataracts. And actually hypocalcemia, so certain metabolic conditions predispose patients to cataracts, and it's hypocalcemia rather than hypercalcemia. So it might be a difficult question, but it's key sort of just to understand which risk factors lead to cataracts. So cataracts is just a natural, normal aging process where the lens becomes more opacified. It's the leading cause of blindness worldwide. Risk factors, so obviously age is the big one. We went through some of the others there as well. Presentation, we've been through that. So yeah, so on the actual examination, you get the loss of the red reflex because you have the cataracts in the way of the retina, so you can't see, so you wouldn't get that red reflex. And another thing is halos around light. So say people driving at night, they'd be like, oh, the headlights of people coming at me, there's like halos around them. So there are three types of cataract, depending on where the cataract starts to form within the eye. Nuclear sclerotic, cortical, posterior subcapsular. I don't think that's particularly important for med school exams. However, it's just nice to have a bit of like context. Treatment is so there's not any sort of, there's probably sort of like trial based treatments and possible treatments out there, but actually I don't think there's anything that can actually sort of reverse or stop the development of forming a cataract. So you sort of just do watchful waiting, list them for cataract surgery, which is phacoemulsification. So you extract the cataract, so the lens, and then you put in a fake lens, an artificial lens. Important just to have a bit of a think about sort of complications from surgery. So obviously endophthalmitis, you can get retinal detachments, and then posterior capsule rupture, so the back of the sort of the lens bag can rupture, and that's when, if you're trying to put an artificial lens in, it can sort of disrupt where that would sit. And then posterior capsular opacification, so the back of the bag, so the lens is sort of sat in a bag, and that they call a capsule, and then the back of that can opacify, so that you need further laser treatment to treat that. Okay, so I'll hand over. I'll give you guys a second to read and answer the question.
Okay, hi guys, so I'm taking over now. If we can flip to the next slide, please, Alex. Oh, so the answer was, so can you flip to the previous slide? Yeah, thank you. So the answer was A, type 2 diabetes mellitus, or just diabetes in general. So yeah, next slide, please, Alex. So the patient presented with a retinal detachment. So I know sort of the stem might have been a bit misleading, because another sort of potential differential could have also been a vitreous hemorrhage, which I think somebody selected hypertension. So there's also an increased risk there. If you think of, high blood pressure in the eye, it can cause sort of a hemorrhage within the globe itself. However, this patient had sort of a sudden onset painless vision loss, which kind of indicates a retinal detachment rather than a vitreous hemorrhage, because you wouldn't expect any vision loss with a vitreous hemorrhage as well. So retinal detachment, so it's the detachment of the neurosensory tissue at the back of the eye. It's deemed as an ophthalmic emergency, so patients need to be seen within the first 24 hours of their presentation. The condition is normally reversible and treatable, providing that they are seen within, those first 24 hours. So generally, the ophthalmologist might do, like a surgical repair, something like a retinoplexy or a vitrectomy. So some of the risk factors as follows. So diabetes, just because you're at increased risk of developing diabetic retinopathy, myopia, so short-sightedness, age, trauma is another one as well. So, like close contact sports, or sort of patients getting into fist fights. I touched on briefly some differentials to consider as well. So again, vitreous hemorrhage. And management is fairly sort of straightforward in terms of what we would need to know at this stage, or sort of for the UK MLA. So just to be aware that it's an urgent referral to ophthalmology. They'll probably examine the eye under slit lamp. They might also request for an OCT, to see if there's any macular involvement as well, and then proceed to surgery as they see fit. So yeah, next slide, please. Okay, so answer is non-proliferative diabetic retinopathy. So if we can go to the next slide, please, we'll just explain this a little bit more. So the patient, in terms of their risk factors, we can see that they had from the stem hypercholesterolemia, diabetes, and hypertension as well. So one of the other options that was also a choice was proliferative diabetic retinopathy. Sorry, Alex, we can go to the previous slide. Unfortunately, I don't have a pointer, but if you can see sort of towards the left of the image, we can see sort of some yellow areas. So we've got some hard exudates, and then the softer, blurrier ones surrounding that to the sort of far left of the image, sort of soft exudates. We've got some flame hemorrhages seen in the upper right area of the photo, and we've got some tiny sort of dot blot hemorrhages or microaneurysms as well. So we can see 4 vessels, each going to the 4 quadrants, well, 4 vessel pairs, each going to the 4 quadrants of the globe, leaving from the optic disc. So not instinctive, sort of indicating that there's any sign of neovascularization. So if we go into the next slide, if that's okay again, thank you. So with diabetic retinopathy, it can be classed into proliferative, non-proliferative, and maculopathy. So with diabetic retinopathy, it can then be split into mild, moderate, and severe. Really, for like non-proliferative, I think the best way to sort of understand the difference between maybe the different subcategories is to, have a sit down, have the images up that you can find from like sources such as PassMed or Zero to Finals, and then you can compare and contrast between each of the 3 subclasses as well. But mainly, as you can see, it's sort of the progression of the disease. So features of aneurysms, blood hemorrhages, hard exudates, sort of features that we saw in the previous slide. And specifically for proliferative diabetic retinopathy, you're looking for that neovascularization. So I've got an image on the next slide that we'll show shortly. And it can be quite common with proliferative diabetic retinopathy, more common in sort of type 1 diabetics as well. Yeah, if we can move on, please, to the next slide. So it doesn't show any of the other sort of distinctive signs that we saw in the first image, but you can see, apart from the 4 vessel pairs, you've also got sort of these new sort of windy vessels that have also been formed. So that's quite a key distinctive feature of proliferative diabetic retinopathy. And sort of something to sort of bear in mind, when you are being sort of tested or you have an exam, sort of look out to see if there's any sort of new features of any new blood vessels forming. So overall, with diabetic retinopathy, you expect patients are often asymptomatic quite early on. They might experience other features, such as floaters, blurred vision. Some instances they might sort of develop like a red tinge to the vision. So that could be signs like, of a vitreous hemorrhage, but that potentially could be quite late into their condition as well. But the main features that we sort of have to manage with them, is diabetic control. So if they're on the right medication, are they complying to it? Do they need to potentially increase whatever medications that they're on? You potentially start insulin treatment as well. With non-diabetic retinopathy, non-proliferative, sorry, it's just mainly closely observing the patients, so that annual sort of checkup with the optometrists and potentially the ophthalmologist as well, depending on how severe it is. With proliferative, if we see sort of changes in visual acuity, then you can consider, anti-VEGF inhibitors to prevent the new blood vessel formation, but specifically with proliferative diabetic retinopathy. And if, depending on how severe sort of visual acuity has been affected, patients could also be referred for like pan-retinal laser photocoagulation, so basically zapping the back of the eyeball to try and reduce the number of vessels. But patients potentially could also have a reduction in the peripheral vision or the areas that the laser treatment has been administered to. Yeah, so if we go on to next slide, please. Okay, so question 8 is orbital compartment syndrome. So I think one of the answers in the chat, somebody selected CT head. So orbital compartment syndrome is a clinical diagnosis that's made, so something that you have to treat immediately. A few sort of red flag features to sort of be aware of. You've got proptosis on the eye. It's very, very, very painful, very tender and hard on palpation. So just like, you've got compartment syndrome in the leg, this unfortunately is happening sort of around the eye, so kind of behind the ball globe. So just like with sort of regular compartment syndrome, it's, pain that is sort of hard to, like, pain out of proportion, sorry. So sort of think of it like that. So with a CT head, I can understand why you might want to have a CT head. You might want to see, potentially if there's like basal skull fracture or any other fractures that are contributing to sort of the blood loss or the bleeding that's happening. But a delay in the CT head could also, sort of cost time to the vessels and the optic nerve as well that supply the eye. Packing and dressing is not really appropriate because you're probably sort of applying more pressure and sort of increasing the pressure within the eye itself, so the intraocular pressure. Surgical drainage, that potentially could be what the ophthalmologists choose, but there's sort of bit more ideal management, so the urgent lateral canthotomy. And 48-hour outpatient is potentially going to be too late for the patients as well. They're at risk of losing the globe the more time that's delayed for them to get the treatment. So if we go into the next slide, please. Thank you. So we've just got an image here. So like I said, it's basically sort of a build-up of sort of blood sort of behind the globe, as you can see here. And it's sort of increasing pressure within the globe, and it's preventing, because of the pressure build-up, the drainage of the fluid out of the eye. So what they want to do, the surgeons will make an incision line here and the lateral canthal tendon to allow sort of for the pressure to be released and sort of drainage as well. Strict bed rest is advised because sort of any movement can cause like a redistribution of the blood or potentially cause an increase of blood and sort of increase of pressures build up as well. Sort of causes, so like we've talked about with this patient, trauma, also other causes, potentially surgery if a patient's on anticoagulation and they might have had a fall, so again trauma, that's also causes an increased risk of bleeding as well, and potentially orbital cellulitis. Next slide, please. Yep, so we've got age-related macular degeneration. So mainly so because you can see quite a lot of drusen sort of within sort of around the macula as well. So we've sort of touched on already diabetic retinopathy. With photocoagulation, you'd sort of expect to see sort of paler areas within sort of on fundoscopy and sort of bigger circles than this, if you will. Hypertensive retinopathy. It's it is a good differential to be aware of, and I think a lot of times with MCQs they try and trick you out on this topic as well. But remember, you'd often see other signs as well with hypertensive retinopathy. You might see some papilledema, you might see some flame hemorrhages. You also will see some hard exudates as well, but we can't, the optic disc isn't enlarged, so it's not sort of showing signs of papilledema. We can't see any hard exudates either. And we've sort of talked about proliferative diabetic retinopathy. So if we go on to the next slide, please. So macular degeneration, so it's the most common cause of blindness in the UK. It can be characterized by two types, so wet and dry. So dry is sort of gradual degeneration of the macula, as wet compared to wet is sort of you see choroidal neovascularization and bleeding. A lot of patients report central vision loss and distortion, and a lot of times sort of patients will be given like a piece of paper with lines on, for example, and when they're looking at the paper they might see, instead of straight lines, the lines might be distorted and a bit wavy. So that's sort of another key key investigation, if you will, to be aware of. On a fundoscopy, like I said, you'll see sort of the drusen. You might see sort of the neovascularization and sort of subretinal hemorrhage sort of within the globe as well. You can request an OCT, and that might show fluid or thickening sort of under the retina as well. So to manage this, there's with dry AMD, it's just sort of monitoring and focusing on any sort of contributing factors such as smoking. With wet macular degeneration, it's very similar to sort of proliferative diabetic retinopathy. If there's neovascularization, potentially anti-VEGF injections as well, and just a lot of support to patients as well, because they're experiencing vision loss and central vision loss, and it can be quite, just like with any of the conditions today, can be quite daunting for them as well. So yeah, as you can see, age, so over 75, you're 3 times more at risk. If you smoke, family history, and other comorbidities as well. So next slide, please. Oh. Okay, so question 10. So this question was about anterior uveitis. Some people might have also heard it because like iritis as well. So with this question, again, it's asking what the most appropriate next step is. So we want to start, some topical corticosteroids, and cycloplegic agents such as atropine, for example. So if we go on to next slide. So anterior uveitis, so it's the most common cause is idiopathic. We don't know why it happens, it just happens. So you generally see a unilateral painful red eye. Patients, so sort of sudden onset, patients describe photophobia, blurred vision, and a watery eye. You also expect to see sort of a small irregular pupil, and on a slit lamp you might see some anterior chamber cells and a flare, and possible as well, you might see can never say this word, hypopion. If Alex can jump in, how do I pronounce this?
Yeah, hypopian.
Thank you. Thank you. Some risk factors as well. So autoimmune is this is one of sort of the HLA B27 diseases. So, if you see a stem and it says a patient has a past medical history of ankylosing spondylitis, that alarm bell should be ringing and sort of associate that with anterior uveitis as well. But on the other hand, they potentially could put that in to trick you. So just kind of be aware. IBD and psoriatic arthritis. Other causes, sort of, HSV, varicella, TB, and syphilis. And like I said, most of the cases are idiopathic. So if, a patient's got sort of an underlying infection, you treat that potentially with some, especially with the HSV and varicella, antivirals. But the key thing is to be aware of, it's an urgent ophthalmology referral, so sort of within 24 hours, just so they can get the necessary treatment to be started as well. Okay. I think we've pretty much reached a time. Does anybody have any burning questions in the chat? Hopefully, you guys have found this useful.
Please ask any questions. And I've put a feedback sort of form in the chat as well. Please, can you just fill that in, and then you'll be able to receive a certificate as well. And it's really useful for us to have some feedback. Sorry, go on. Were you going to say something? Cool.
Oh, no, I was just going to say good luck to everyone who's still got their finals. And to not worry, everybody has their like weak spots. Ophthalmology is certainly not one of my strengths, but I think a lot of these, it's all about pattern recognition. And what really helped for me last year was I had kind of like a big A3 paper or equivalent on like my iPad GoodNotes. And I literally, as Alex said at the start, split it up into kind of red eye versus non-red eye, vision loss, like non-painful versus painful vision loss. And that really helped to sort of like hone things in for me. But yeah, sorry, go on, Alex.
No. I think you're right. Have like a good system for opthal presentations. And opthal is hard, but I think we went over a lot of key points there. Things that you just need to spend time on is the diabetic retinal signs and stages, because it feels like it's something they won't ask you, but it does come up. Same as like hypertensive retinopathy. So just make sure you know your stages and the signs, and then if you're at that point, then you should be doing okay with ophthalmology. But yeah, we'll stay around for a few more minutes if anyone wants to ask anything or write anything in the chat. But yeah, as I said, the feedback form's also in the chat. So thank you very much, everyone. And yeah, we'll see you next Thursday.